Hello, this is Stephen Holloway. We're going to be discussing Module E, Nursing 202, Module E, genitourinary disorders. We're mainly going to be talking about men's health and male reproductive disorders today. So let's get right into the lecture. We're going to start out by talking about benign prostatic hyperplasia, or you may hear the term benign prostatic hypertrophy. The newer term is the hyperplasia, so you may hear or read either term as you're going along. Your reading assignments are your IGGY, your Med-Surg book, Chapter 75, that's required. That'll take you through the majority of the men's health issues that we'll be discussing. I found several articles or several helpful articles in the Nursing Reference Center, which if you'll go to your main page, Calhoun main page, click on Library, go over to the left-hand column, you'll see Nursing Reference Center. Go ahead and open that up, and then the articles that I really want you to look at are benign prostatic hyperplasia, prostatectomy, benign prostatic hyperplasia, and the one you must read, there will be test questions from it, are bladder irrigation continuous. Again, this one's under a different tab. If you'll click under the skills procedure tab and then type in bladder irrigation, continuous, it will take you to that. I also recommend, if you still have your anatomy and physiology book from that you go ahead and read that chapter on the male reproductive anatomy, because I'm not going to take time to go back through anatomy and physiology as we cover this. We have enough material to cover already. So when we look at BPH, benign prostatic hyperplasia, we're going to look at the incidence, the pathophysiology, clinical manifestations, treatment, and then the postoperative care. Postoperative care is going to be very important. That's where that article really comes into play that I want you to read. When we look at the incidence of benign prostatic hyperplasia, the incidence of benign prostatic hyperplasia is the most common neurologic problem in adult males. It occurs in 50% of men over the age of 50, 90% of the men over the age of 80. 25% of men require some type of treatment by the age of 80. Does not predispose that person to the development of prostate cancer, though. So just make sure, as we're going through this, you understand it does not increase the risk of prostate cancer. When we look at the pathophysiology of the BPH, what we're seeing is just because of the overgrowth, there is an overgrowth of the tissue within the prostate itself. And because of that overproduction of this tissue, it begins to cause a narrowing of the urethra. This narrowing of the urethra then causes problems with urinary elimination. You can see this is just a cross-cut section and see how the hyperplasic cells here are pushing in. Many times you'll also see it push back up into the bladder neck, causing more problems. If you remember when we talked about urinary stones, if we get blockage in these areas, remember, it can back up. We can get backup of urine into the bladder, from the bladder into the ureters, and then into the kidneys. This is just kind of a cross-section showing you again the bladder, the enlarged prostate, how the urethra is compressed. It can also cause some problems. Men will actually begin to feel pressure in the rectum and feel like they need to have a bowel movement because the pressure. Again, it's going to depend on how large that prostate gets with this process. When we look at it, the exact etiology is really unknown as we look at the whole process. We do know that the incidence increases with aging, and we think this may be a normal aging process. The other thing that we look at is a hormonal, and we see increased levels of DHT in these patients. That DHT causes that proliferation of the prostate cells, causing that growth, that hyperplasia, which then causes those type of things. The bladder, or the lack of urinary elimination. Physical changes we talked about. You have the enlargement of the prostate, and that enlargement of the prostate causes obstruction of the bladder neck, and that obstruction of the bladder neck can cause the backup of urine. Clinical manifestations that we may see in BPH are something you will hear the term LUTS, L-U-T-S, which is lower urinary tract symptoms. The patient may complain of urinary frequency and urgency. They may complain of difficulty in starting or stopping their urine stream. They'll complain of hesitancy. They'll notice a reduced force and size of the urinary stream, a weak stream. They may have sensations of incomplete bladder emptying. They have to work so hard to try to empty that bladder, but they can't empty it. So there actually may be more urine left in the bladder. They may have to strain to start their urination, and again, they may have post-voiding, dribbling, or leaking. Many times these men will complain of nocturia, which is having to get up and void during the night. As we move into taking care of these patients, we need to assess that patient. There are forms and different types of scales out there that will help in doing a summary or a quick assessment of these patients for their symptomology of their prostate symptoms. The IPSS, the International Prostate Symptom Score, is just one tool that's out there. That is on page 1631 of your 7th edition of your IGGI. This is what it looks like, and these are the questions that are going to be asked of the patient. Many times these are just given to the patient and have them circle the answer. Now, always good to sit down and explain to the patient, this is what we're having you do, this is why we're doing this, and many times that's the responsibility of the nurse, especially if you're working in a physician's office, to set these up, get with the patient, sit them down, and have them work through these. You can see questions asked are basically, are you having problems with incomplete emptying? How often have you had the sensation of not emptying your bladder? With 0 being not at all, and then almost always a 5. It asks them about frequency. How often have you had urinating less than every 2 hours? Intermittency. How often have you found you've stopped and started again when you're urinating? Urgency. How often have you found it difficult to postpone urination? Weak stream. How often have you had weak urinary stream? Straining. How hard do you have to strain? How often? And then nocturia. And then the last one is more about a quality of life. Basically looking at those. There is a score that is assigned to these, and based on that score, the physician or the advanced practice nurse will make a decision on how bad the hyperplasia is, and then basically start beginning to look and develop a treatment plan for that patient. Part of the other assessment, which is not something that nurses do, it is something that advanced practice nurses will do and physician's assistants, but a digital rectal exam. And as part of that digital rectal exam, as nurses, you will be preparing the patient for that. You will make sure the glove is there for the physician. There's KY jelly for lubrication and tissue for the patient to wipe. You probably also want to have a Hemocult card available, because the majority of the time while we're doing this prostate exam, we're also going to be doing a Hemocult just to be on the safe side while we're doing those type things as well. Now, when we're doing that digital rectal exam, it can be done because that prostate is really so close to that rectal wall. It's very easily palpated through this process. Typically, you want to have that patient just bend over the bed if they're able to stand. That's probably the easiest. Or put them in a side-lying fetal position. It's just whichever is easiest for that patient. When we do the digital rectal exam, what we're looking for is the size of the prostate, the consistency. A patient with BPH, the prostate just feels kind of uniform, elastic. It's really not tender. It's not enlarged. Whereas if we're looking for cancer, you may feel kind of a stony, hard nodule on there. If you're doing that digital rectal exam and you feel a hard area, kind of very rough area, that just sends off a red flag. I need to follow up and check this patient for cancer more than anything else. Now, if this patient has been having dysuria, having burning on urination, during this time we may go ahead and basically massage that prostate and try to get a sample of the prostatic fluid to check for infection. What you'll need to have most of the time is just a glass slide so that fluid can be taken, or a culture swab, so you can basically send it to the lab to be looked at under the microscope, and then you can do a culture and sensitivity on that. If this patient does have prostatitis, then it's basically treated with broad-spectrum antibiotics for at least 30 days to prevent the spread of the infection itself. But that is something you may see done while they're doing the digital rectal exam. Labs that we draw on these patients as we're beginning to look at them, we're going to get a PSA, a prostate-specific antigen. There's a lot of controversy right now. How specific is this PSA? Does it really tell us what we want to know about the patient? So you may hear more and more about different changes. I think it's a good thing as we're looking at BPH and looking for treatment of cancer for patients, because once we notice that it's elevated and we treat the patient with cancer, we should see that PSA come down. The other thing we may look at is a serum phosphatase level. Alkaline phosphatase and acid phosphatase show different types of cancers for those patients. We want to get a chemistry 7. At chemistry 7, we're really looking at the electrolytes, but the big thing we're looking at is BUN and creatinine. Does this patient have any renal problems, any renal failure? Has this been going on long enough that we begin to get the backup of urine and causing damage to the kidneys? The other thing we'll get is a CBC, again looking for signs of infection. We're looking for the elevation of the white blood cell count. The other thing we're looking for when the CBC is we also may be looking for anemia. If this patient has a cancer, one of the signs can be hematuria. You can also see hematuria with some of these patients as well with the BPH, but not as likely. But if the hematuria has been going on for a while, we may see a decrease in the H&H and the RBCs. Of course, we're going to urinalysis and a culture and sensitivity. We're going to look at that urine. We're going to look and to see what color it is. Is there any hematuria that we can see? And of course, we're going to look at it microscopically as well. And we're going to look at a culture and sensitivity to rule out any type of infection going on. And then we talked about the culture and sensitivity of the prostatic fluid if we do a massage of the prostate to express any fluids. Other diagnostic tests that we may do on these patients are a transabdominal ultrasound, looking to see if we can see how large the prostate is. More effective is the transrectal ultrasound, where you go into the rectum, because again we talked about that the prostate is closer to that rectal wall. We just get a better visual on the ultrasound of that. One of the things urologists will do sometimes is actually do a cystoscopy, where they can go in and see the amount of blockage that is being caused by the swollen prostate. So those are something that you may see done. Urodynamic pressure flow studies, I've not seen these done, but this is basically looking at how the pressure of the stream as the patient is doing it out, being able to urinate. The other thing you may see done sometimes is a bladder scan. Again, what we're looking for in that aspect is a post-residual bladder scan to see is that patient retaining urine afterwards, and how much and how consistently are they retaining urine. Again, that retained urine can set that patient up for a urinary tract infection, for cystitis, for hydronephritis, for backup of the urine, those type things. So those are some of the things that you may be part of as we take care of these patients with BPH. Again, we talked about that. When we look at BPH, okay, the nursing diagnosis that most commonly is used is impaired urinary elimination related to bladder outlet obstruction, and you can easily see that when you looked at that schematic of how large the prostate get and how it squeezes on that. Treatment goal, or the expected outcome as we call it, treatment goal is going to be for the physician's expected outcomes. What we're looking for is for the patient to have a normal urinary elimination pattern without urinary hesitancy, urgency, or infection. So what is the treatment? What is the treatment for these patients with BPH? Well, the treatments can be non-surgical and surgical. non-surgical treatments or drug therapy, which we'll talk about, complementary and alternative therapies, we'll talk a little bit about that, and then there's some other things that we need to teach the patient as we send them on their way about those things like drinking fluids, avoiding certain foods. Those type are some of the ones that we're going to be looking at as we move along. Surgical treatment for these patients basically can go anywhere from a transurethral resection of the prostate, which is the gold standard. The newest thing coming along that may take over as the gold standard is the holmium laser enucleation of the prostate. Basically, it uses a laser to basically burn away the cells of the prostate so that now that prostate is shrinking and we no longer have that process. The transurethral needle ablation, the transurethral microwave therapy, interstitial laser coagulation or contact laser prostatectomy, and the electrovaporization of the prostate are all different types of processes that may be done. Let's talk just a little bit about each one of these surgical processes that the patient that may undergo. The transurethral needle ablation uses low wave radio frequency to actually heat the prostate cells and causing necrosis. It's done on an outpatient procedure. It very precise delivery of heat to the desired area, has very little pain associated with it. One of the big things that most patients are happy about, it causes very little erectile dysfunction and retrograde ejaculation. They're both very rare with this procedure. Now, some of the disadvantages are you may have urinary retention for a while after this is done because of the heating of it. The patient probably will experience some hematuria. And with the majority of these, you may need retreatment because it doesn't necessarily take care of all of the hyperplasic cells. They may come back as the patient progresses in age. So that's one you may see done. The tuna, or you may hear it called tuna. Okay, the other one is the transurethral microwave therapy. Basically, just like a microwave works to heat up your popcorn, your food, they use a microwave to radiate heat to produce coagulation and necrosis of the prostatic cells, those hyperplasic cells. Again, done as an outpatient procedure. Very low risk of erectile dysfunction and retrograde ejaculation. Big problem is it can be potentially damaged to surrounding tissues because of the heat that's generating. These patients may need a urinary catheter for a while after the procedure, and they may need retreatment again because it does not take care of all of that. With a lot of these treatments that you're seeing, many times they will put in a stent afterwards to kind of help hold open the urethra where these are, because you can also get scarring of the urethra. Remember, you're having to actually go through that urethra to get to the prostate as part of that. Now, the laser prostatectomy basically is a procedure that uses a laser beam to cut or destroy part of the prostate. As I said, the holmium laser is probably one that's used most often. But basically what you see is a very short procedure. It's very comparable to the results of the transurethral prostatectomy. So minimal bleeding, which is very good because that's one of the big problems with the TURP. Fast recovery time, rapid symptom improvement, and tends to be very effective. Now, some of the drawbacks to the laser type process is the fact that the catheter has to be in place up to 7 days. That's because of edema and urinary retention. You may have a delayed sloughing of the tissue, so it may take several weeks to reach optimal effect, and they can have retrograde ejaculation as part of this process. Now, the transurethral electroevaporation of the prostate just basically uses an electrical type of device and basically just destroys the prostatic tissues. It does have minimal risk, have minimal bleeding and sloughing that go along with it. Does have problems of retrograde ejaculation and intermittent hematuria from this. So that's one of those that you may see. Again, the big thing is, as we look at these patients, when we look at invasive type treatments, the transurethral resection of the prostate, the TURP, is the gold standard, and we'll talk a little bit more about that as well. Patients who have a very large prostate may have to have an open prostatectomy, which is not something we want to do. That's a very invasive surgical type procedure, typically reserved for patients who have an extremely large prostate or have prostatic cancer. So that's not something we're going to look at very much till we get to prostatic cancer. The other thing that we may do to treat these patients, and typically the very first thing that we do to treat these patients, is drug therapy. The drugs of choice right now are the 5-alpha reductase inhibitors. They're the first-line drug, your Proscar and your Avodart. Those are your major drugs that you will see being used for these patients. Now, when we look at these drugs, they work basically by blocking the conversion of testosterone into DHT in the prostate. This decrease in the DHT then causes a decrease in the proliferation of the prostatic cells, and thereby decreases the size of the prostate. Now, you need to be careful with these drugs. They do have side effects, as all drugs do. You want to remind your patients who are being treated with these drugs, the 5-alpha reductase inhibitors, they need to take it for as long as 6 months before they can see improvement with these. Teach them about possible side effects, things which may include erectile dysfunction, which is the biggest reason most patients will stop taking them. They may have dizziness because they can cause orthostatic hypotension. So you want to remind them to change positions very carefully and very slowly. But most of the time, what we're seeing is because of the effectiveness of the drug therapy, that the number of TURPs has drastically reduced over the last 10 years. The other drugs that you may see used are your alpha-1 selective blocking agents. And you've all heard of these. The Flomax is probably the one that you've heard most of. You've seen it advertised on TV. It actually can be purchased over the counter now for these patients. With these drugs, the Uraxtrol, the Cardura, the Hytrin, the Rapaflo, all of these, if you'll notice, all of these drugs tend to end in OSIN, OSIN, OSIN. So you can see that these drugs are of a particular category. So if you see those drugs, you know they're an alpha-1 selective blocking agent. But you go down here and look and you think, Cardura. I see that used on the cardiac floor. They use that for blood pressure medication. Same thing for Hytrin. I've seen that used for blood pressure medication too. And you are correct in your analysis of that. These medications also lower the blood pressure. That's one of the big problems with these medications, is we have to be very careful because they will create orthostatic hypotension for these patients, can cause tachycardia and can cause syncope. So we want to be very careful, especially the first time we give the patients these medications, especially if they're in the hospital, and especially if they're an older gentleman. We want to make sure that they understand to change positions very slowly. If they need to get up out of bed, sit up first, sit there for 2 to 3 minutes before they stand there for 2 or 3 minutes before they start trying to walk. Unfortunately, many patients have been injured by trying to jump out of the bed, and that goes back to that urinary urgency. I've got to go, I've got to get up, I've got to go. They've just been placed on these medications, and boom, they hit the floor because of the orthostatic hypotension. Also be aware that drugs to treat erectile dysfunction, such as Viagra, can actually make these effects worse. They can actually lower the blood pressure even more. But these drugs are very, very good in doing that. Again, we need to make sure that these patients keep their appointments with follow-up with their physicians. There is blood work that needs to be done, as these drugs can cause liver dysfunction. So we need to get LFTs on these patients on a routine basis after we start the medication. The alternative medication that you're going to see most often for these patients is saw palmetto. It is a herb that has been given for years. There have been studies that show that it is no more effective than placebo. A study was done I'm sorry, I've lost my spot here, but there has been a study done and looking at the effects of saw palmetto, and basically the study showed that it is no more effective than placebo. Now, unfortunately, sometimes it's very difficult to convince your patients. They will tell you, yes, it's better. Yes, it's better since I'm taking this medication. If they're not having any side effects, this medication is not interfering with any of their other medications, it's not worth the fight to try to stop them from that. But you just need to make sure they understand it can interact with other medications, and make sure they let their healthcare provider know that they are taking this herb with their regular medications, so that as we begin to adjust medications, we can know about that. Other therapies that we as nurses need to teach the patients about is to avoid drinking large amounts of fluids in short periods of time. That basically is going to increase that fluid in the bladder, increase that urinary urgency, urinary problems. So we need to make sure not drinking that. Alcohol and caffeine need to be avoided, again, because of the diuretic effects of both of those. Avoid any drugs that cause urinary retention. A big thing that we see with that are your decongestants. The pseudoephedrins, those type of things are basically going to cause increased urinary retention. So we need to advise our patients, if you're taking cold medication, make sure you look to see that it doesn't have a decongestant in it. If it has a decongestant, it may make your BPH and your urinary symptoms worse. And we also need to teach our patients, void as soon as they feel that urge. Go ahead, get up, empty your bladder, because as that bladder gets more full and more full, it's more difficult for them to empty the bladder. The problems tend to get worse as they're going through that process. When we talk about surgical treatment for these patients, we're really going to talk about the TURP, transurethral resection of the prostate, or the TURP is what you'll hear it called most often. This basically is the gold standard for treatment of these patients with prostatic hypertrophy, or hyperplasia, excuse me. This works by insertion of a cystoscope, and it actually goes in, and you have a picture of this in your book that talks about that whole process of going in. And what it does, it basically removes chunks of that prostate. It goes through and using an electrical cautery type device, actually takes out chunks of the prostate. And then basically as those chunks fall back into the urinary system, either going into the bladder or they may go into the tract itself. But basically, you're going through and trimming that out until you get that prostate small enough that you can now have an expansion of the urethra so that urine can pass through very easily. Disadvantages of this procedure is trauma to the urethra. You've got to go through that urethra to get to the prostate, so you're actually causing trauma to it. You can also get a regrowth of that prostate tissue if you don't do something to block that production of DHT. Then you're going to get a regrowth. So many times you'll see these patients, even after this, put back on some of the medications to block that production of DHT. Unfortunately, some of these patients will have retrograde ejaculation as part of the process. Rarely you'll see nerve damage, and you'll see erectile dysfunction as a part of this process. Much less likely now than it used to be, and a lot of that's going to depend on the skill of your surgeon, how many times your surgeon's done this process. So those are some of the things that we need to talk to patients about and remind them that these may be happening. It's if they have questions, get their physician back in to talk to them about that surgery. Our big thing is taking care of these patients after they come back from surgery. This is major surgery for these patients. They are going to be kept inpatient after this surgery. When they come back, they're going to have in a 3-lumen catheter, and that may be in place for several days. This catheter basically has your balloon port, has a port for your fluid to go through and to fluid to go in and irrigate the bladder, and then a port for the urine to come back out. So it basically has 3 ports. Now that catheter, we need to make sure we're applying traction to that catheter to keep that bulb up next to the opening of the bladder. It is our responsibility to monitor the color of the urine drainage and take a look at that. If you'll look in your book, in your IGGY book, chart 75.1, it talks about care of that patient after that TURP. So we're going to monitor the patient closely for signs and symptoms of infections, especially our older population, because they may have underlying chronic diseases such as diabetes, cardiovascular disease. So we need to make sure we're monitoring for that. We want to try to get that patient up and moving as soon as possible. And the reason for that is, number one, prevent pneumonia. Number two, to prevent VTE, venous thrombotic events. So we want to make sure we're getting them up and moving them. If they're in bed, and we need to make sure we have those sequential compression stockings in place on these patients. We need to be assessing that patient every 2 to 4 hours. Part of that assessment is taking vital signs, looking at the urine, and looking at what the color of the urine is and how consistent it is. If the bleeding is very bright red or ketchup light with lots of clots, that may indicate arterial bleeding. And if there's arterial bleeding, we need to notify that surgeon immediately so they can come in and take a look at that. So what we're going to do is if there's orders for it, a lot of times we'll go ahead and irrigate with normal saline till the physician gets there. Many times these patients have normal saline or glycerin going as part of that process already. Again, if it's more of a burgundy type colored without any changes in your vital signs, that's probably venous type, but you still need to let your surgeon know that this is going on. Both of these can actually result in anemia from the blood loss, so you really want to make sure that you're doing those type things. You want to look for clots. You want to make sure that catheter is draining, because those clots sometimes can block that outflow port. So if you've got continuous infusion going in and the output port is blocked, then that fluid is building up within the bladder of the patient, which can cause pain, can cause more problems. So you're continually monitoring your output, your flow of solution in and your flow of solution out. Most of the time, if there is looks like it may be blocked, there are orders for manual irrigation, hand irrigation, to try to remove that block. But you still need to make sure you're documenting that. And if you've irrigated and now more bright red blood's coming back again, notify your surgeon. Sometimes these patients will go home with the catheter in place, so you want to be teaching about the care of that catheter at home. You want to talk to them about drinking 2,500 to 3,000 milliliters of fluids per day. Again, that's going to be patient by patient. If you've got an older patient with congestive heart failure, you're not going to send them home on those type of fluids. You may have to do a less of a thing. Read that article on continuous bladder irrigation. Very important. It can be very confusing if you've never done it before. The bags typically are 3,000 liter bags, and they are hung 2 bags flowing in. Can be either a glycerin solution or normal saline. Most have switched to normal saline because the glycerin solution can cause some bigger problems with changes in electrolytes, those type issues. So most of it's going to be saline. Those need to be labeled, and make sure you have it labeled for urinary infusion, not for IV infusion. You don't want to get those mixed up. You need to be monitoring how much fluid is going in, how much you're taking out of that, because the difference, your urine output is the difference between how much went in. You take how much you've gotten out in the Foley, subtract how much went in on the infusion, and that will be your urine output for the day. So you've got to make sure you're measuring the urine output. Everything you empty from the Foley bag is not urine output. So make sure you understand that as you're going along. You want to monitor the labs on this patient, because we are irrigating. Normal saline is isotonic, so that's why it's best. But if you're using glycerin Monitor the patient's electrolytes, monitor the patient's H&H and red blood cells to make sure there is no signs of anemia with these patients. It's our responsibility to take care of these patients when they come back. Again, that's one of our big things I want you to focus on as you read that article. Just a quick summary as we looked at BPH is what we discussed. Remember, it's the most common neurologic problem in males. 50% of men 50 and over are going to have some sort of problem, so that's very prevalent, and that goes up as they get older. And remember, our population is getting older, so you're probably going to see those type issues whether you're in the hospital. You may just be giving the medications for these, but you will be seeing these patients at some point in time. Diagnosis is based on the patient's symptoms, how many symptoms they have, based on a digital rectal exam, and it's your responsibility as a nurse to help get that patient prepared for that digital rectal exam. Some of the other things that we may do for these patients are ultrasounds, cystoscopies, flow studies. All of those may be done to help take care of this patient. Your responsibility as a nurse may be to administer that International Prostate Symptom Score summary to these patients and collect that from them and give it to the providers so they can make an adjustment on what's going on. Remember, there are non-surgical and surgical treatments for BPH. The non-surgical treatments are pretty much taking over now. We have the two types of drug therapy. We have the alpha 1 selective blocking agents, which were the first drugs used. Those all work by relaxing the smooth muscles in the prostate gland, thereby decreasing the urinary resistance and improving flow. But those also come with side effects of orthostatic hypotension. The first-line drugs now are your 5-alpha reductase inhibitors, things such as Proscar and Avodart, so you may be giving those to the patients. But again, they can come with side effects as well, so we need to make sure the patients understand the side effects of those medications. Treatment of choice, the gold standard, of course, is the TURP, the transurethral resection of the prostate. If you work a urology floor, you will be taking care of that patient. And that is one thing I want you to focus on as you study for this exam coming up, is that care of that patient after that transurethral prostate resection of the prostate. Make sure you understand the continuous bladder irrigation, the trilumen catheter, and taking care of that type of a patient for you. That's what I have for you on benign prostatic hyperplasia. I wish you good luck on your exam. Thank you.